Welcome to the Reverse Mullet Healthcare Podcast from BP2 Health. Today we're talking with our very first podcast guest, Dr. Carol Pittman, about the challenges of getting people to take an active role in their own healthcare, aka patient engagement. But first, who are we and why are we here? And more importantly, I'm kind of getting used to it now, but why did we call this the Reverse Mullet Healthcare Podcast?
Well, we want to be relevant, informative, and creative, but we also want to be entertaining and have fun. So it's a party in the front and business in the back, like a mullet, only reversed.
I'm Ellen Brown.
I'm Justin Politi.
And I'm Dave Pavlik. We are passionate, innovative, and collaborative, and we're committed to solving our industry's most important issues together with our clients. We have a combined 90 years of experience.
Makes us sound so old.
In each episode, we're going to dig into hot healthcare topics and dig into each other a little bit.
But you have to be gentle on me.
Now, we've what did we talk? Noogies last time.
We're going to be gentle with Dr. Pittman. You are fair game.
Yeah.
Always. Yes, we will be. They will be on their best behavior for you.
That's true. But I am super excited because we do have our first guest today, Dr. Pittman. Dr. Carol Pittman, with over 25 years experience in healthcare as a physician leader who's passionate about patient-centered care delivery. She's currently the National Senior Vice President of Clinical Operations for P3 Health Partners. And prior to that, she has an impressive tenure that includes President and Chief Medical Officer of Optum Colorado Springs and Regional Medical Director for DaVita Medical Group, just to name a few. She also happens to be a board-certified internist with an MBA who practiced as a hospitalist early in her career and even started and ran her own medical practice. We've had the pleasure of working with Dr. Pittman on a number of initiatives at P3 regarding to ACO REACH, and her passion for patient and the physician is always present.
So, Carol, how did we get lucky enough to have you in Tampa Bay?
Well, I am a Florida native, so my family still lives here, and so came in for Thanksgiving. However, during Thanksgiving, we had a new arrival of my first grandbaby,
Yay!
Wellesley Joyce. Yes, she's almost 2 weeks old, so very excited about that.
And how long are you in town?
I'll be here until about 3 more days.
Till the baby's 3 years old?
Yeah.
No?
Little did they know.
Yeah,
Right.
exactly.
I moved back.
Excellent.
So what's it like having a grandbaby?
Oh, it's awesome. She's just so tiny. She's, my children were not that tiny. She's just the cutest little nugget you ever wanted to see.
Aw,
She's
I saw the
amazing.
picture. She is adorable.
Have you already made your return plans?
I have. Yep. Luckily, it's a one-way flight. It is a one-way flight to Vegas.
It's a nonstop flight.
It's a nonstop flight to Vegas. Yeah.
There you go.
Excellent.
So, I actually want to hear about, can we talk about the Harley Fat Boy for a little bit?
There was a time in my life where, yes, I rode a Harley Fat Boy for, lots of fun, and then just decided to give that up a little bit.
How did you learn how to ride a Harley? Did you take a class?
I did.
Okay.
Yeah, you have to take a class, and you have to have a motorcycle license, and so you have to go through the testing, and it's a written test and it's a road test, and it was just like a weekend class, and then they set you free on the road on that big machine.
Wow.
But it's because it's not.
Here we go.
I don't think it's specific to a Harley, right? You just do the
it's just a
motorcycle license, and then
motorcycle
you can get on a
license.
big Fat Boy
Yeah.
or a little scooter.
Yes.
But aren't Harleys something specific, though, that you have to learn about a Harley, or no?
No.
Not really?
No.
I always
No.
thought that, but maybe no.
No, my dad had one. Did you know this? Are you
No.
aware of this fact? Yes. Gary Rowe.
That's not surprising.
It's not surprising that my dad had one.
No.
No.
With his
He was
car-
a Corvette, and then he which I
likes
drove
fast
all
things.
the time. He likes fast things, cool things. So yeah, he had a Harley. I used to ride. The longest trip I took with him was to Atlanta.
Oh my gosh, that's a
And I was,
really long
from
trip
Florida.
on a
Yeah,
motorcycle.
yeah.
Florida.
That's
I thought
a
it was
long
so
ride.
Yeah.
great.
Because it takes forever to get out of Florida, right?
It does.
Let me guess. Ellen had her golf clubs on the back.
No, that's
this was
for
a golf
another.
tournament.
That's for another episode. No, I wore a bikini top because I was
there
a
we go.
teenager. Yeah, it was
All
like
right.
a whole. Yeah.
I kind of
Actually-
like the golf club image personally better, like with her, like
Come on,
stopping
what are you
along
saying?
the way.
You don't
going-
want to see me in a bikini
No,
top? Like
well-
that's a little bit. I mean that's a little.
All right, it's a PG show here.
All right, fine.
You guys probably don't know this. My actual very first vehicle was a motorcycle.
Really?
Yeah,
Is it like
Really?
a dirt bike?
No, it was a street legal motorcycle. I had to get the license, the Class C motorcycle license also.
Okay.
Mine was,
You had long locks of flowing hair at that time.
but I was wearing a helmet, so you couldn't see it. But I had a Honda 125. And
I asked you if it was a dirt bike.
No, it was a street bike.
I understand, but you get my point.
But look, I rode the Beltway around DC, 65 miles an hour on this tiny little thing with a friend on the back. It was like not safe at all.
Okay, well, the last thing I wanted. Okay, so you asked about the Fat Boy, and I want to hear about because you guys know me, the nutty, crunchy nature lover. I got to hear about this U.S. park aspiration you have that you're working towards.
So my goal is to go to all 63 national parks.
All right.
In my lifetime.
Okay.
I think I have a pretty good start.
Yeah. So how many do you have now?
About 25, I think.
And you did like most of them.
A couple of years ago, I was transitioning into P3,
okay,
where I currently work, and I had some time off, and so I spent basically 90 days going around to parks in the West, national parks in the West,
which is just outstanding. And you camped a lot too.
Yeah, it was a 6-week straight camping, tent camping, real camping.
Like 6 weeks of tents.
6 weeks of tents. I will say there were a few hotel stays.
There's got to be like some hot showers in your
or
own
a good
room.
shower. But yeah, it was great. I mean, basically, I went from the Mexican border to the Canadian border to the Pacific coast, and
So jealous.
It was really cool because my sons were able to join me. So my youngest son was with me for the first about 3 weeks or so, and then I switched him out in Portland, and my older son came with me on the last leg of
That's cool.
the trip, and we popped out in Las Vegas, which was interesting.
Yeah. You know, my husband and I on our honeymoon, we did a camping trip, and we went from Salt Lake City down through Colorado, back around, and ended in Vegas. So similar thing.
Yeah,
you know, spent some time in the middle of nowhere in Utah, like in Canyonlands, in like the needle. Like my husband had like heat stroke one night. I didn't even know what that was at the time, and I mean he was obviously fine, but it was pretty scary. And we're like totally in the middle of nowhere. And then I think 2 days later, you know, we're in Vegas, and it's just such a shocking transition back into humanity, you know, it's like a different variation. So did you have a last question? Did you have a favorite park?
You know, every park has its superstar gem piece of it.
Okay.
It's so hard to pick a favorite, but if I had to, and if you forced me to,
okay,
I would probably say Yosemite was just incredible, outstanding. But they all have their special attraction within the park.
Yeah.
They're amazing.
No, I would totally agree with that.
Is Yosemite Old Faithful?
No, that's Yellowstone.
Yeah, that's Yellowstone.
Right. That's how much
Yellowstone's
I know
cool
about.
because it's got all the different regions, and you know, I won't keep going on national. That'll be like another podcast on the side, talking travel.
Right.
Talking travel with BP2. All right, so before I want to go back to your professional side for a minute, and then we're going to jump into our topic. But we asked, you know, when we were prepping for this, right, we asked them different questions. And I thought you explained to us how you had developed a physician leadership program. And I would love for you to tell us about that, because I think that's the kind of work that is so needed. But then it kind of, A, it's not necessarily focused on, and B, when it happens, it's sort of like, oh, I got to do that on the side, even though it should be like what we have to do, you know. But so I don't know if you would mind taking a minute to tell us about that.
Sure. I was fortunate that I was kind of pulled in and brought into a lot of leadership pilots in a previous employer. And so the capstone project of one of this leadership development courses for me was a project. And so I decided to do a leadership, it was called a lead physician leadership program. Because as physicians, we're not, we're kind of like leaders by default, but we're not really taught how to lead teams and how to procure teams and excel with that. So I had a great partner in the development of it and the implementation of it, and we rolled it out to, first it was to lead physicians, you know, on their initial path into being a medical director or a chief medical officer. But then it was like, well, you know, this isn't really specific to physicians. It's about leadership.
Yeah.
So when I was in Colorado Springs, we actually did this program for our clinic managers. And so, because it could be operational, it could be clinical, but it really was emphasizing on, how to be a strong leader, how to build a strong team, a lot around emotional intelligence, a ton around emotional intelligence, but really how to prioritize your goals so that, you can achieve the goals that were set out by your organization or you personally. So it was very rewarding, very fulfilling.
Okay.
Yeah. Teaching is my love. Fills my cup.
Dave?
All right. Well, yeah, before we jump into patient engagement, let's introduce our sponsor for this series of episodes, our friends over at Incline Actuarial Group.
Shout out to Colby and Jerry.
Yes, love those guys and
the
their
rest of
team.
the team.
Yeah, they're great. They're not a one-size-fits-all approach at Incline. Their actuaries have multidisciplinary backgrounds across healthcare with experience in Medicaid, rate setting, price and risk-bearing providers, Medicare ACO analytics, risk adjustments, and reserving. They don't just check the box by repeating the same analytical approach. They strive to find creative solutions that are custom tailored to the problem. Their actuaries work as affordable staff extensions of small businesses. Furthermore, they specialize in serving government agencies to support public sector healthcare. No matter the size of the engagement, their actuaries work with clients in a transparent and efficient manner that highlights areas of risk and doesn't overproduce the analysis that is requested. And you can find them at www.inclineag.com.
So when we shared with you our mission for the podcast is to discuss real change in healthcare, we asked you what topic you're passionate about, what needs to get addressed in the healthcare system to work again. You suggested this hot topic of patient engagement. So what does this actually mean?
So I'm going to weigh in really quickly. I think the thing I wanted to point out was that when people talk about healthcare, it's like a right. It's this non-negotiable. It's everybody gets on their high horse about healthcare, and then it's the complaints. I can't get it. It's too expensive, and so on. But yet, when people are facing chronic conditions, when they need to be most present with their healthcare, and they have health benefits, they disappear, right? Like it's like, and it just boggles my mind. I mean, right?
Yeah.
So do you want to start with definitions, Dave?
We often do start with definitions.
Right.
Ellen usually breaks out a
Webster's.
a Webster or some actual.
Have you ever heard of Funk and Wagnall?
I have.
All right, finally.
Somebody's heard of what?
Yes.
I never said I didn't.
The problem
know
is
Funk
She's
and
like
Wagnall.
searching around for Funk and Wagnalls, can't find it. It's like fake
not a
looking.
thing anymore.
The
It's
problem
not a
is,
thing.
no, they have a website, and the problem is it's an encyclopedia, and there's not a definition for most things.
They have a two-part.
I think I know what I'm getting
Dictionary.
you for Christmas.
All right, so
Anyway.
all right,
All right.
we'll table
Well,
that.
I'm going to give a
table that for
definition,
Dr.
and then I'm
Pittman,
going to hand it over
Carol
to
knows Funk and Wagnalls. That's all we need to know
All
about
right.
the program.
Let's just ask
So you're-
Dr. Pittman how she defines it.
All right, how do you define it?
I think that patient engagement is really being an active participant in your healthcare and not a passive one. I see a lot of times that patients are very passive in their healthcare. They don't ask a lot of questions. They're not educated about the chronic conditions that they have. So for me, patient engagement is very, very simply being active in your healthcare, knowing what's going on with your healthcare, understanding the frequency of how often you need to see your physician because of your chronic illnesses, engaged in taking your medication. So medication adherence is huge, as we know, in the quality space.
So for the layman, what is medication adherence?
Medication adherence is that when you're prescribed medication, that you are taking them appropriately. You're taking them as many times a day as you need to, that you're not missing doses, that you're getting your refills in a timely manner. And also adherence to a treatment plan, meaning that it should be a treatment plan that both have agreed upon, the physician and the patient, right? And so that's the opportunity to ask questions about, well, what do you mean with that? Or why are we doing that? Are there other options? So that's kind of co-creating a treatment plan, but then following through with the treatment plan, right? If it's diet or exercise or whatever else it is. You can go on and on. Vaccinations. Did you get all the vaccines that you needed,
Yep.
right?
Yep.
So I think that's really and engagement also is having the relationship with the physician that you're my guy or you're my girl, from a physician standpoint, that I'm going to call you first and I'm going to run it by you, whatever's happening with me, and I'm not going to run to the emergency room. If I have a cold or a cough or I'm having chest pain, as long as it's not, serious, I want, as a physician, I want you to come to me first.
And because you've established some trust there.
I've established trust. We have a relationship. And the stronger the relationship, the more engaged the patient is going to be. And all of that just leads to healthier outcomes.
Yeah, you also mentioned, I don't want to get ahead of ourselves, but you did say that a lot of times patients are, they just don't ask enough questions. So you might say, here's what the treatment plan is. You okay with this? Sure. And
Right.
they may not even really know what it means.
Because they may be embarrassed to ask questions. Like
that's
they may
interesting.
think that their question is dumb or, not relevant, but it's as a physician and you're sitting in that room, you're thinking that they're absorbing everything. They're probably absorbing a tenth of what you're saying them, depending upon what you're talking to. So also having written instructions for the patient is really helpful, because they're going to leave that and they're going to go, I don't remember anything they just said.
So is health literacy part of that equation?
Agree. Absolutely.
So can that be confused with somebody who's disengaged? They just don't understand?
It could be. I think, a lot of the things that we talk about with patient engagement is also, are they doing the tests, the preventive screening tests? STARS, HEDIS is a big topic in healthcare right now. And we have a really hard time getting patients to do their mammogram, do their colonoscopy. And so that's leading to disengage, or it's being perceived as disengaged.
And
as well.
what do you think the barriers are to people doing that? Like to going and getting the mammogram or getting the pap smear? Like what do you think some of the barriers are for that?
It might be that they don't feel that it's important or understand how important it is. I mean, every mammogram is a potential to have early detection of breast cancer, right? The same thing for colorectal screening. It may just be not clear on the why of it, and not having someone to have them talk to about the why with it. A lot of other things, this can go into a lot of rabbit holes, right?
Yes.
Is it transportation? Do they
Right.
have the money for the copay of that test? There's just, and did they even get into the doctor? So access is a big thing, right? And could they even get into the doctor, for the doctor to have the opportunity, or the nurse practitioner, or the NP, to write the prescription
Oh, it's hard.
for that?
It's really hard. I mean,
So access is huge.
Yesterday, my endocrinologist had given me a ultrasound script 3 weeks ago. And I've already not done the ultrasound for a year. It's something I have to do every year, but I had to switch doctors. Took forever to get in, right? Finally see this person. And then as we talked about at dinner last night, I am a very engaged patient. I think
That's the word, engaged.
Gold star.
this table actually believes that I'm overly engaged, perhaps. Although I will say I have stopped using Google Doctor. I am no longer
thank
no
goodness.
longer
Right,
Dr.
so now
Google.
she's
Justin,
got
no more
every
Dr.
ailment.
Google.
This long list of ailments.
That's the worst
I
thing
have
you can
taken
do.
that out of the equation because I could be dying at any given
Right.
moment.
I go to Dr. Giggles.
That's Dr. Giggles would be much better. Anyways, I've had this script sitting in my drawer, and do you know that you guys will never guess? Take one guess. I just am curious of the barriers to why I did not make the appointment.
Lazy.
Nope.
No, there's
Forgot
no way
about
it's
it.
laziness. Like, it's
Nope.
got to be top of mind.
No,
There's just
because-
doesn't fit within her schedule
Well,
for,
that-
say, 16 other different things.
Well,
is what I'm
okay.
thinking.
That clearly is
doesn't-
an underlying
Those are
factor.
obviously none of the answers.
No, but the answer, although that was definitely a subliminal theme going on in the back of my
Right,
mind of,
right.
there are other more pressing items to deal with today than scheduling this. But it was because I asked the endocrinologist, is there a particular facility that you would like me to have the ultrasound, right? Like, would you like me to go in some? And she told me, and I promptly forgot which facility that was. And so I literally didn't schedule it because of that. And so my point being, here I am, this like uber engaged patient, and even I blew off something that I actually asked for when I went in, because I said, this is something she's like, yes, you should do this year. And so.
Well, I think access is this huge issue that you brought up, because think about it this way. If I
and what's
you're
access?
planning 6 months
Again,
out,
for the layman, what is access?
being
when it
able to
comes
actually
healthcare?
be able to interact with your doctor and get an appointment
Yeah.
within
Or,
a reasonable
like Carol
period
said,
of time.
having transportation to get there,
Well,
right?
Those are all the external things. I'm just talking about scheduling the appointment itself, and
Getting a slot on the schedule.
Right, and then you're like, because we have this instant society that we live in, right? And I got to wait 6 months in order to get a wellness visit. You're kind of like,
Well, and you always schedule it. You schedule this appointment 6 months out, and you have no clue. And then you get closer. You're like, oh, that's not going to work. So then you call to reschedule, and they're like, oh, that'd be another 6 months.
Right.
Yeah, that's the reality of how we're accessing
Do you think
things.
telehealth could, do you feel like that's something we're missing in healthcare, that we just haven't adopted it to the extent that we should from a reimbursement perspective? Like, if we could make telehealth more readily available and acceptable?
I think it definitely helps. I mean, we see it helping in our medical group as well. So, but it has its place. I don't think that every patient could be treated with telehealth, because there's nothing that's going to replace the human touch in an exam.
Yeah.
Right. So I think it does have purpose. I think if it's something simple, if you look at the younger population, they probably would rather do a telehealth visit, because then they are not taking time off work and the drive time and all of that. So it makes it more simple. I think with the older, with our senior population, what we see is they may not all, but they may not be as tech savvy. We have some really tech
I know my
savvy
parents,
seniors,
they are not
right?
tech savvy.
So it's, there's a lot of platforms for telehealth that are just difficult to get on, right? And get that connection. One of the interesting things that we're doing is that in one of our markets, we have hired a company that employs paramedics.
Okay.
So the paramedic goes to the home, is basically like a home site visit, right? And then they connect the patient to the provider via telehealth. So now all that pressure is
like the
not
facilitator.
Yeah, so all that pressure is not on the patient to, do I have the right kind of device? Can I connect to the device? And then, on the other side, you have a physician that's on a schedule still.
Mm-hmm.
You only have a time spot. And so then if it's difficulty for a connection, then you're chewing up time of that virtual appointment. But yes, it definitely has it. I think that we can continue to expand it.
Yep.
It doesn't replace a face-to-face, though, right? You still, to have a really engaged patient, there needs to be some hands-on,
absolutely,
face-to-face in the office.
Yeah.
So how do you build that relationship now when we're talking patient engagement and the interactions that have to happen to get
I guess what I should say is, it's hard to fathom. I'm digressing for a second, because I want to go back for a second, because this kind of started the conversation when we were talking to you initially about this. So now I've given you the task of remembering to say your question again, which is just, I can't even remember the question.
It's already gone.
It's already like
she hopped in.
But
Pushed you aside.
Right, she hopped in with her thought right here.
yeah, Dave says it like it is. No, you just dismissed what I wanted to ask.
Right, exactly.
Well, I just wanted to hear, because this is the part that just blows my mind, like I said before, is that it is a problem. So has this always been a problem, the lack of patient engagement?
I was thinking about this on the drive-in today, and, the majority of my career was in Florida, either as a practicing physician or in leadership and as a medical director. In Florida, I do not remember having this degree of disengagement from patients. So I was thinking about that, and I said, well,
versus Nevada, versus
right,
the markets you're in now,
versus,
and which markets,
or wherever
you're.
Well, we are in Florida,
okay,
Arizona, California, Oregon, and Nevada.
Okay.
What I see, and I was wondering, well, our business is value-based care. It's Medicare Advantage primarily, right? Florida's model of care in that is long. So are the patients more engaged because they've been in that model more?
Yeah.
And so we've trained them or taught them, right, how to become more engaged, and the providers as well. maybe that's why it's not as much of an issue in Florida, whereas a younger market that we're entering that doesn't have value-based care models or Medicare Advantage, the patients aren't used to this type of, frequency of visits and the engagement and the stars and the HEDIS and all that kind of stuff. So that could be part of it. But I will say the other thing that I've recognized, whether it's true or not, just my perception is I've seen the big shift after COVID. And so I don't know if COVID had anything to do with that, because what did we do in COVID? We were basically scared to have patients come to the office, right? Because we didn't want to continue to spread COVID. So we treated them with telemedicine, or we treated them over the phone, or we extended the frequency of their visits so that they were coming in every 6-9 months, maybe one time a year, and not every 3 to 4 months like we would like to see them, because we were just scared and it was new and didn't know what was happening, right? So I don't know if that's left an imprint on patients where it's now
Like they're almost scared to come in the office.
Well, why do I have to come in so often now? I didn't have to during COVID.
Yeah, nothing
right?
bad happened to me during
nothing
that
bad happened. Yeah. Why do you need to see me so much? So I'm not sure if that's part of it as well. But I think, going back to Justin's comment about access, there's a PCP's. See, I remembered for you.
Exactly.
And took it off of your plate, Justin.
Thank you, Carol.
Carol's good like
I know.
that.
We're gonna have a phone a friend during the next one.
That was my idea, by the way.
Right. Ellen interrupts, and I'm like, all right, Carol, what
did Ellen
what
say?
was Justin saying then?
What were we talking about?
Access.
But with access, we know that there's a primary care shortage. In one of our markets in Arizona, we have, the entire state, and a lot of it is rural populations. And there's just not enough access for patients to get in. There's not enough PCPs. So you can't have patient engagement if you never see the patient and you don't have access. Mm-hmm. And on the other side, it's, the providers are seeing a ton of patients a day, right? And so when you're seeing a ton of patients a day, it's not like they're seeing 5 patients a day and there's no access because they don't want to see patients. Their schedules are chocked full of patients. And then in this, get me on my soapbox here, and then the fee-for-service hamster wheel, right? Yep. There's no time for acute visits or triages. So what happens? If the patient does call and say, hey, I've got a sore throat or I've got this belly pain or whatever it is, I'll see you in 3 months, to your point, right? And so where does the patient go? They go to the emergency room or urgent care, right?
Because they can't be seen. So when you talk about again, I know I drive everybody crazy, but there are a lot of people I know that want to listen to podcasts like this to learn about healthcare too. So when we talk about the fee-for-service hamster wheel, how would you sum that up for somebody, what that even means?
Yeah, so the fee-for-service hamster wheel it's a per click or a per unit, right? So the access is created because, everything revolves around the revenue at the end, right? Everyone has to have a salary. You have to have, revenue for operational expenses, all that stuff, right? So you have to see more and more patients.
To get more and more money.
To get more and more money just to be sustainable and break even.
Which then means, which then breaks down to... So for those that don't know healthcare well, at more of a technical level, right, the issue is, I have to see a bunch of patients, as many as I can, which means I can't spend much time with them, versus if I was getting paid, and this is why we're working with you all on a different model of versus fee-for-service. It is still technically fee-for-service, but it is a model where your organization is really getting the total dollar to manage on behalf of the patient, the person, the Medicare eligible person, so that you can be more of a steward of that. And if you wanted to, you could create a model where physicians, like you talked about with reimbursement, maybe they're getting paid a salary where they're actually incented to spend more time with patients. I'm not saying that's happening, but it does create, that's why we always talk so much about this term payment transformation, because it is all interrelated. When physicians have the time to engage with patients, it's a two-way street. It's not just getting the patient to come into the office. It's getting the patient to feel like when they come in the office, it's worthwhile.
Absolutely. So if I'm on that fee-for-service hamster wheel, right? And I have 10 minutes to spend with you. How much of a relationship are we building?
Absolutely.
No, and you're behind the
We're
computer entering information with all
You
the
have to.
documentation now that you have to with it,
Right.
for documentation. So it's kind of just like you're being interviewed.
Right.
It's been my experience. I know we talked about this last night, but I'm just interested, like, where did we really, if we're to go back, like, where do you think we really went off the rails here with this being able to build relationships? Because it wasn't that long ago where I felt like,
You'd come to the ranch. The doctor would like ride the horse to the
Sure.
ranch and see the family
Yeah.
and have coffee.
right, they have the leather bag and they're coming in and they know,
Yeah.
right.
You
But
know what I'm talking about, Dave? That was last week.
That's how it works in my neighborhood.
Yeah, I think there's more and more, and let's not forget about the providers, right? So there's more and more pressure for the providers to see more and more patients because we have to meet ends meet, right? And the only time that you, in the fee-for-service world, that you're making money is you're seeing patients, you're doing procedures, you're doing surgeries, et cetera, right?
Yep.
And so there's an enormous pressure on physicians to see more and more patients. And it's hard. I mean, we've heard a lot about physician burnout. Let's not forget about that. And so if you're going into work every day and you're like, I've got 20, 25, 30 patients, and I've heard of some physicians seeing 60 patients a day.
Insanity.
One, we're not giving good care, not because it's not a good doctor, it's just because they don't have enough time to give good care. And we're not building the relationship. And going back to, if I'm sick and I call and I want an appointment with you today and you say, I'll see you in 3 months, I'm teaching the patient, well, why am I even going to call anymore? I'm just going to bypass you, go to the emergency room, and now you don't even have, an opportunity to build a relationship with me.
I mean, I do that with my own kids. We've done concierge medicine a lot.
They can't get an appointment with you?
No. My children?
Yeah.
No, you guys see, that goes right over my head. I'm like, yes, concierge medicine. Yeah. No, I'm actually proud of myself. I have really worked in the last few years to reprioritize and have a lot more time and space for the kids because I traveled too much before COVID and, those kinds of fun things. But if you could redesign things to optimize patient engagement, to make it work better again. And then I have another question that I have to try and remember. But I mean, what are some of the things that you would do? Not necessarily just patient engagement, but that would help patient engagement get back to what it needs to be.
I think we do that in our organization. And I think anyone that's in value-based care is trying to do this as well. It's really having meaningful time with the patient.
Okay.
You have to have a long enough appointment that you're able to address. You can't address everything because, some patients will come in with a list of things that you probably do
And
that.
Ellen has this list.
Everyone looks at me.
It's this long, right? And we've got 5 minutes.
And it's not in that font.
No. Right.
But it's really having the time and the space to sit down, not feel rushed, have a conversation with the patient, learn about the patient. So it's not just about, we know how to build relationships, right? And so if I keep it all superficial, I'm really not going to get to know you. When I was in practice, I made it a point, the first couple of minutes is, how are you doing? How are the grandkids doing? Tell me about the dog, so that there was kind of a social interaction and I'm bonding with them and creating a relationship. And then we'll get into the meat of the
So
visit.
there you go. You're the reverse mullet of healthcare practice, right? We're the podcast. You're the physician, the reverse mullet physician. You have
Carol,
the party in the front.
We do have a wig that you're
and we know that you don't want to
Right.
wear it.
But I think it's having the time to spend with the patient. Absolutely having the time to spend with the patient. And that is access, right? And so if you're carrying a large panel of patients that come and see you, you're not going to have the luxury of having that time.
So less patience.
Right. So
creates more time.
It's less panel of patients. It's, at least 20 minutes for a follow-up visit. If you're doing a more detailed exam, it's, maybe that's 40 minutes or something. So you can't do that in the fee-for-service world, right? Because it's a click. It's a per click.
So P3's approach is to have the clinical team, involved with patient care through P3, they understand your priority is actually to spend time with the patient.
Absolutely. Right. And to build a care team around them so that everyone is supporting the patient, supporting the physician.
What do you think some of the most integral components to the care team are?
One of the things that we put in place in our medical group in Las Vegas was an RN that serves as a triage nurse and a care manager in the clinic.
Okay.
And so now the patients can call and talk specifically to the nurse if they're having, an issue, and they can kind of triage them, and they communicate with the physician, and then they decide what the disposition is going to be. Am I going to bring them on the nurse schedule, which is kind of an extension now of the provider, right? Or am I going to put the patient on the provider schedule where the nurse can see the patient quickly, get all the information, do a cursory exam, and then present it to the physician, and you can kind of speed up that visit for an acute visit.
So it's an extension, like you said,
Yep.
of the physician. Okay. All right.
So considering in a perfect world, you're seeing your patients 3 to 4 times a year. Even with that, you're spending maybe an hour or two face-to-face with the patient over the course of a year. So real engagement has to go beyond that face-to-face visit. So whether it's a portal, other information that gets pushed out, what kinds of things do you consider to be best practices kind of beyond the exam room to keep that engagement going?
Yeah, I think patient portals are really important. A lot of the patient portals, they can get in and they can see their test results, right? And they can even see the notes. But also the patient portal is a good avenue for education. So if it's created appropriately, they can go in, they can click on, heart disease or diabetes. And so trying to keep them interactive with that. There's kind of a debate on how much engagement versus patient abrasion. Right.
What is abrasion?
So a patient abrasion might be I'm calling the patient to get them to do something, right? Whether I'm calling you to get your mammogram scheduled, or I'm calling you because you need your annual wellness visit, or I'm calling you to make sure that you're taking your medicines, or I'm calling you, so I'm calling you.
And they're not calling you back.
A lot of patients don't even answer the phone because if they don't recognize the number, I'm the same way. If I don't recognize the number, I'm not answering the phone. I'll listen to the voicemail.
Right.
So there's an issue with technology and the patient abrasion, right? So you don't want to abrade the patient because you don't want to push them away, but you're trying to get them to do things. So from the portal perspective, I think that's really important. I think online scheduling would probably help as well.
Yes.
A lot of people are going to online scheduling.
Yes.
I love online
great.
scheduling.
Yeah.
Because you feel guilty, right?
Yeah.
Like when I talk to a doctor's office, and unless you call, I did on the car yesterday driving over here, I called and made the ultrasound appointment. And what I love about things like that is they say to you, I have you down for this appointment. You need to arrive. I'm like, did we discuss when the appointment would be? They just dictate when the appointment is, right? When it comes to like the more procedural things, like this is when we will see you and you're like, oh, okay, I will have to make that time work. But when I'm talking to one of my typical doctors, you kind of feel guilty with the office manager. Like, well, that doesn't really work for me. What about this? Well, that doesn't work for us. Okay, well, what about this? And you feel like you're having this.
It's a bartering.
Yes, and you feel like you're wasting their time. So when you have the online tool.
What's the app but the meeting scheduler thing, that time?
Well, you've sent it to us, Dave. Not Sign Up Genius. It's a name.
But that feels like it should work for scheduling an appointment.
But I think the problem is each condition is going to take up a certain time slot, and it's hard to give the patient the autonomy to say, I want this 30-minute time slot for my cough versus, the office might say, no, you're getting a 15-minute slot for that. You'll get a 20-minute for this. You might book 2 or 3 in that slot. And, so
the common thing is to have a templated schedule and
wellness.
What kind of appointments go in there.
Yeah.
The other thing from a technology standpoint is texting or emails, right? And so I think it's probably less abrasive than continuously calling someone. So we're looking at using, hopefully in 2024, more texting Because then I'm more likely to respond to a text
Absolutely.
and yes or no, or, or just a text reminder. So
Yeah.
I think that would be helpful with engagement as well.
So can I shift for a minute?
Yeah, we're going to have to wrap in a
we have
couple
to
of
wrap.
minutes. So
So, all right. So I know we're not going to sing the song, but
I'd like to teach the world to sing perfect harmony. I'd like to buy the world a Coke
And keep
it company.
Okay.
It's the real thing.
All right.
All right, so now we're going to get shut off by
now we're
Chloe.
done.
Yes, we actually sang it.
Right.
This is going to become a tradition. But in that vein, right? What I wanted to ask you, we asked you this ahead of time, is if you had a buy the world a Coke moment, and you could wave a magic wand and do what you'd like, what is the thing that you would like to see addressed or fixed in the healthcare system? Something you're really passionate about.
Let's just fix the whole thing.
From the ground up. That's
Soup to nuts. That's what I
Justin-
said.
All right, well, that's
That's
fair.
my 3 o'clock in the
Let's just-
morning.
Justin
the
dreams
whole
about
thing.
that all the
That,
time.
like, just eradicate everything and start
Let's just
fresh.
start all over again.
Bomb it. And go, yeah. All right.
Let's just fix the whole thing. I like where we're going, and I know it's been a slow start to value-based care because now it's not the per clicky thing, right? Where physicians can actually look at outcomes. As physicians, we're just naturally competitors, right? So you compare me against, my partner, I always want to outdo them, right? So I think there is something to that, but we have to always put the patient first. We always have to put the patient first. We always have to make sure that whatever we're doing in healthcare is going to provide better health outcomes. And whether that's tied to revenue, bonuses, incentives, whatever it is, then let's do that as long as we're making our patients healthier. That's the key.
So Justin, you get the last one today before we wrap up.
Because if you're looking to be a physician, right, we're discussing getting into the industry, like all of these challenges, like why would you come in today? How do we reinvigorate that part of, that passion for medicine that used to exist, or I feel like it's kind of gotten squashed out by what is happening in the industry today? Like how do we, from your perspective, how do we
Or what
reinvigorate?
legacy, right? Like what legacy would you like to kind of leave in healthcare?
To Justin's point, like I would love to reinvigorate the love of medicine. I think that, a lot of times the business of medicine gets in the way. The politicking of medicine gets in the way. Just like let us see our patients and do our job and not, say we have to see 50 patients a day, right? Give us more time. Make sure that the compensation is appropriate, but help us measure outcomes. We have a ton of data, right? And a lot of people don't use the data to measure outcomes to actually know, am I making my patient healthier? So I think if we saw that, we would eliminate burnout, give me more time to see my patients, give me quality time to see my patients. All of those things would lead to less burnout.
And let physicians get back to why they
Let's
started
just get
practicing
back
medicine.
to doctoring.
Yeah.
that's buying the world a Coke.
It is. Well, it sounds like we need to be an army of folks that are out there that are pushing this. When I say pushing it, because we've let it get to this point collectively as a society. Now we have to be fighting to get it back.
Yeah. Let's go.
Let's go. Where are the swords?
All right.
Dr. Pittman, thank you so much for being here
Thank
with
you.
us
It's
today.
been a pleasure. Thank you so much.
Well, thanks again. I'm Ellen Brown.
I'm Dave Pavlik.
And I'm Justin Politi.
She's Carol Pittman.
And we are the partners at BP2 Health. Your best chance for real change. I got it right today. As you can tell, we could talk all day about healthcare, which is why we started the podcast in part. And for those of you listening, drop us a line through our site, bp2health.com.
The Reverse Mullet podcast is produced by MMG Studios in Tampa, Florida with Victoria and Gunther.